that affecting revenue and reduction. Item 3 is the minutes, which have been circulated. I'm going to record that previously.
Work-life balance to encourage people back in. We've also addressed some issues, certainly around some of our community staff as well, around provision of additional support, bearing in mind the cost of living increase, with additional payments for the petrol claim, etc. So there are a few things happening in this system.
What's changed there?
And helping. One of our biggest priority items.
Are we still charging staff for car parking?
I'm afraid I don't know that question.
You know, some hospitals are not keen to let them away anything, particularly decided to not charging staff for car parking. One of the incentives. I've raised it a couple of times. I don't know whether it's been considered because it's one of those simple things. And attracting staff.
Yes.
There was issues about discharge problems last time. Do we know where we are with that? Has that improved in terms of ability to discharge patients?
Well, there was supposed to be an update on that.
Sorry?
It was supposed to, according to the minutes.
Yeah, that's right. Yeah, that's why I'm asking.
So presumably that's coming up in the presentation, is it?
Not. Perhaps I should set the scene in that I am very new to the system. So I arrived recently from Australia, dealing with many of the same issues, it transpires, the same challenges the world over. So I'm new to the ICS. So there will be a number of committees that are going to be a first time around for me. So certainly in being asked to come here today, I've put together from my area of work for strategy and integration a picture of where we're up to, what next, some of our biggest challenges, how I think we'll be looking to address those and discuss some of the timelines. I've also left some space in there for us to talk a little bit more openly about relationship with yourselves in overview scrutiny, how we can work together and bring some of those conversations in here. If there's been something in process that's not been passed to me, then I'm happy to have a stab at answering what I can today, but it may be what I might have to do is take them on notice and agree to come back and discuss them.
Have you got more?
Oh, yes, lots more.
Yeah.
Yeah.
I wanted to follow up on this
Oh,
one
okay,
because
yeah,
that was
yeah,
mine.
yeah, no problem.
One of the questions I asked, because we were told there was going to be a new system within the hospitals for discharge, so that there were 3 points in the day when you looked at discharge and so on. And one of the things I raised and never got an answer to was the 24/7 care, because we know, and so did Healthwatch Shropshire know, that actually we have a number of people stuck in hospital from Friday afternoon right the way through. And in the case of my daughter with a child, a baby, newborn baby that had to have a kidney scan, she was stuck from the Friday all the way through, and they told her she couldn't have one until the Tuesday. This is bed blocking in a major fashion, but it's happening to ordinary people with no pharmacy, no regular radiography, and doctors available actually to discharge people. There's a huge range of things. So that, for me, and the freeing up of beds and therefore its impact on the rest of the hospital, ambulance response times and the rest, is a really vital point to this, because we shouldn't have people stuck in hospital because of the hospital not having the right staff in place. Yes. So if you can touch on that, that would be great. If not, we need an answer urgently.
Yes. So I mean, you're right. Discharges historically have been quite a problem, and that touches as well, of course, on the burning platform of what is ED, and some of the challenges of our ambulances arriving at ED, and the whole thing kind of escalates as one challenge, really, doesn't it? And it's that access block from front door through and out. That there are a number of things kind of happening in that regard. I know our provider organisations of late have been doing a lot of work to increase their ward rounding and activities over the weekend. I know that I was on call this weekend, and I know that I was fed through quite a lot of information at regular points in the daytime, where there were discussions with the medics coming back into the facilities to continue with rounding through the day. Going back probably pre-COVID, I don't know that culturally or historically we were necessarily used to doing that, and it is a change for a lot of our hospital systems to do that.
I think the issue here is, okay, if you can organise that so that the doctors are not so fully stretched that they can actually do their rounds for the discharge, that's one thing. But when you're waiting for drugs and radiography as well, that's a whole different thing.
It is.
And they work Monday to Friday mostly?
Yes, absolutely right. There is a piece of work between now and Christmas. I can just describe or share it very, very high level. I'm happy to come back and talk to it in more detail, that I've been discussing with our chief executives in our provider organisations, which is an approach I've tried in different countries and different systems before. And one of the things that I would like us to do is have a full system capacity review in real time. So not a retrospective look back at what we've been doing with our activity and our data, but really to capture a little bit like a snapshot in time. How have we actually operationalised our business within this period of time? What went well, what didn't, and what are some of the ways in which we can work differently? Because I think we intuitively have a lot of that knowledge, but pulling it out in an organised way that we can then start to build some very focused strategic plans on are another issue. Everybody is in agreement that this would be a really good thing to do. What that would allow us to do is look also at appropriateness and how we might shift where we're providing some of that care and how we're doing it.
And would that include shifting resources to make sure that actually...
Yes, it absolutely would. So one of the things that we'll talk about today, I think, in the presentation is some of the strategic planning processes that we need to move on between now and March. Part of the challenge is, I think, historically, while lots and lots of great work has been going on, lots of our strategic plans have been happening in silos. The hospital has got a very big piece of work that you'll be familiar with around the hospital transformation programme. The community is doing very similar work in terms of the local care programme and so on and so forth. What we kind of really need to do is bring those together as one thing, one integrated piece of work that understands what is it that we need, what capacity have we got in our system, how do we map that out so we avoid duplications and we're plugging the gaps. And there's a lot of enabling strategy work that needs to support that. Workforce is a big one. Shifting resources is another. How we commission and buy services across the system is another.
Okay, so you'll come back to me, or us actually as a committee, around all of this. I think the issue for us at the moment is what quick wins can we put in place to actually make sure that it isn't the hospital stopping people from being discharged, and that it's absolutely clear where the problems in discharge are. And I think that just to ease many of the things that are going on at the moment are that for me, some of the most important things that we need to get back, because those quick wins could make a significant difference. Then the whole piece of work around all the rest of it may need other tweaks to what you've done on the front line, and we need some timelines for some of that, and presumably we will talk about that a bit later, but the 24/7 care and that part of discharge should be a quick win.
Yes.
Could I pause you there, Heather, and you, Dagan, keep your follow-up questions
Because these are all things that we were told last meeting would be updated on.
And I think I'll give you the chance to ask those, but I think what's unravelling is probably your presentation anyway, and I don't want to cut your feet from under you.
Yes, it may be that in the transition of me coming in that not all of your questions have been fed through to me, I would suspect. So I'm very happy to take those away on notice and be a bit more focused on my presentation next time as to what you specifically
We'll see what's not in the presentation, then we'll come back to the questions at the end.
I'll leave it until later.
But do you want to move on with your presentation and we'll see how it goes and take questions at the end?
Absolutely. So noting that you may have been expecting something else, my apologies in advance. As I perhaps said by way of introduction, I've been away from the UK for just over 20 years now, first in the Middle East and then in Australia, but working very much on system integration. And so for me, the opportunity in coming back to the UK at this point in time, when it really is the sort of the subject of the day that we're talking about, was great timing for me. My role within the ICB, as you'll see, is around strategy and integration, and so there are some big programs of work that I'm looking at the moment, by way of what we need to do, by way of some of the issues of timelines, and how some of the priorities will fall out of that for next steps. There's a very big engagement and consultation piece that we need to discuss as a system in taking that forward. So this is an authentic integration and co-design process. So I'll work through that today, and I'm very happy on any specific issues that came through at previous meetings. If they've not come back to you, they're very happy to bring those back in a specific paper. So I apologise if I've missed that.
Right, Dad, can you knock your mic off?
Oh, I didn't know it was on, sorry.
That's it.
Oh, no. Sorry. There's a little bit of a delay on there. Okay. Not being entirely sure of what you've been briefed on before, what presentations you've had from the ICB, I thought it was useful to just start with a quick map there around sort of who and what we are. And forgive me if I'm teaching you lots of stuff you're very, very familiar with, but it's a good starting point, isn't it? That we know around the country we now have 42 integrated care systems that are there bringing together in geographical areas this governance structure, and for us we know that includes our hospital trusts and organisations, both across Shrewsbury and Telford, the Robert Jones orthopaedic specialist Hospital, Shropcom, our community trust, Midlands Partnership Trust, as you'll know, technically being based in Staffordshire, are a provider to us, but clearly a big part of doing our business, and of course the West Midlands Ambulance Service working across all of that. I don't think there are any surprises in that. We know that for us, the specific makeup of our integrated care systems also means that we have the two local authorities and the work that's going on within those local authority areas for the health and wellbeing boards, and that of all our population health and local intelligence. I'm not sure again if you've seen these slides before, but by way of what integrated care systems are there to do, the guidance, and we have had further guidance released now from NHS England. It's perhaps been a little bit slow to trickle out, as I understand it, but there are 4 very key aims that have been pulled out as to the purpose for the ICBs that are really going to direct how we work as systems. The first one, obviously, around improving the outcomes in our population health and healthcare for us across our system. A big responsibility now to tackle inequalities, both in outcomes and experience. And access, of course, is noted in there, which has already been a considerable topic raised by yourselves this morning, very much on the agenda of one of the 4 key points. Supporting that broader social and economic development is where it really starts to move away purely from the health agenda to that of our well-being agenda also. And of course enhancing productivity and value for money. Many people were aware of the old, what was considered a triangle of 3 principles of good governance in health, and obviously we're now seeing a fourth one added there. I don't think I need to read through the benefits lists that are up on there, but I'm sure you have had opportunity to look at some of those before. But just focusing on those 4 aims. A big issue here, and sort of one for me that's sort of quite important, and that's the term integration in itself. In that we talked earlier, a lot of silo working thus far, perhaps within the system, and it's how do we move from what is good collaboration, shared decision making, better governance, to something that is genuinely an integrated system, because that allows us to work really quite differently. It allows us to commission differently, it allows us to look at how we fund things differently, and to pull some of our funding streams that up until now have remained in separate parts of our system. So it really is an opportunity for significant change. And there's a number of aspects of integration that we're looking at as part of this, of course. In one regard, NHS to NHS has got quite a lot of integration to do. That story about transition between hospital and community, stronger roles with general practice, is in itself very much that integration piece across health that we need to continue working on and improving. We could also consider it in terms of mental health and physical health, to kind of really get that better understanding around social care and the wellness agenda, self-care and so on. But also the NHS with broader partners now, with the local authority and with many of our third and voluntary sector organisations. An example of that, I think we already touched on that earlier, is one that's very live for us now. How do we take 2 large change programmes that are happening within our system at the moment, the hospital transformation programme and the local care programme? How do we make sure that they both collectively contribute to a model that moving forward improves our quality of care for our patients, for our communities, and is sustainable? So just a quick flash flag of what the system looks like. Again, apologies if you've seen this slide before. What's interesting, I guess, is as part of our statutory body, there are two elements to this. We have an integrated care board, and you'll be aware that that is termed as NHS, Shropshire, Telford and Wrekin, but we also have a really, really critical partnering agenda there with what will be an integrated care partnership. And this is really where there is an opportunity for health, for social care, other partners in the system to come together as equals, as a statutory committee, working very closely with the board to ensure that there is influence on what we're doing from a system perspective. We're not actually considered to be really fully up and running as an integrated care system until we get that first ICP meeting up and running. We've been through the draft terms of reference, we've been through membership discussions. We're now looking to lock the date in for that first ICP meeting, which will be sometime we think in the first week of October. Given events of the last few days, we know that a few things are having to be rearranged, so touch wood, we don't see too much loss of traction on that. But that is going to be a really, really critical meeting in terms of holding what is the board to account on what it really needs to be looking at from a full system perspective. Within the board itself, of which I'm part, this is what it looks like. So we can see up there that the board will be working very closely with the Integrated Care Partnership. The Integrated Care Partnership is moving forward, I think it's fair to say, on the wealth and experience of a lot of work that's been happening across our health and wellbeing boards over a period of time. We know that within the health and wellbeing boards there is a lot of work that's been done understanding the needs of our communities, what the population health is telling us, where we have some of our gaps. And whilst there are going to be some consistencies of messages coming out from the integrated care partnerships, we also know that there's going to be a lot of local flavour as well, that we need to be nimble and flexible to really make that impact at local levels. Within the board itself and our structures for our executive, we're really focusing on three key areas of work and business for us. Developing our strategy, developing what will be our new delivery models and how we set up our operations, and ensuring that we've got strong assurance through a range of those board committees, as you would expect, looking at quality and performance, finance, audit and risk and remuneration, as you'd expect to see there. All but one of those committees are up and running. Our final committee, which is new to our system ICS Strategy Committee, was actually due to meet on the day of what is now the funeral. Unfortunately, we will need to rearrange that, but that was going to be an opportunity to really start working with partners around how we now start working on the strategic plans we need for the system. And I'm going to come on to talk about those in a little bit more detail. So, two principal important documents between now and between March. One sitting with the Integrated Care Partnership and one sitting with the board. So they both, as you can see, have their role to do with the system. The Integrated Care Partnership has the responsibility by the end of December to have in place what we're kind of seeing as that interim integrated care strategy that will lay out clarity around the needs, the priorities for the ICS. If you like, almost as that blueprint document as to this is what needs addressing, this is what we agree as a partnership across our system we need to be looking at. Once that integrated care strategy is developed, it's handed over to the board. The board then, by the time we get to March, need to do a lot more detailed work on that blueprint to bring that to life with a lot more detail, so that we have the makings then of a 5-year forward-looking plan that will start to put some meat on the bones and start to drive those programs of co-design, engagement and consultation around the priorities that we're actually working on. Move forward and come back to questions. Again, I think given that the timelines are very tight, one of the things that we're very cognizant about, and certainly is a concern of mine, is that we do get it right at the engagement piece and the co-design piece. Between now and Christmas is not a lot of work for our integrated care partnership to produce a very, very detailed plan of work. I think we have to be pragmatic about that, and we have to understand that for this to be an authentic process, we have to continue that piece of work right the way through to March in our work with the board, to be working with people and our communities, that we've got the plan in place that we feel we've all got some buy-in to, and that has had that authentic period of time in consultation and in engagement. I'm just going to flash this up as some indicative timelines. Again, as much as anything, just to demonstrate that there is not a huge amount of time here. I'm going to end this particular presentation with a slide around the what next for us in this environment, because as much as I'm conscious I'm going to go away with some key questions from you that you have that we've not brought back, there is also, I think, an ongoing discussion around how we bring some of the consultation and some of the development of these documents back for discussion and review, and think about the timing of that. Workforce development. Our biggest challenge, perhaps, in my mind, and not only have we got an ageing population that we're caring for, with the needs and the complexities that we need to address, we also have an ageing workforce. With changing expectations, we've come out of a very difficult period of time with COVID. People have had that opportunity to really think around what they want from their work-life balance. And I think going forward for us, when we think through our retention, our recruitment and our ongoing developments, we kind of need to be very cognizant of that. We have appointed an interim chief people officer to the system. The current occupant, highly experienced person, is in fact temporary, but we'll be moving on to a more substantive recruitment for that position in the next few weeks. There is agreement across all partners that is going to be a really important role, an important piece of work that can't be rushed and is very multifactorial. In terms of recruitment, we need to be looking at strategies now to ensure that we do a good job of keeping the staff that we've got. Many people are electing to change their hours, to change how we work, and perhaps therefore some of the traditional ways in which we would have employed people and rostered our work needs to be factored in to that. We need to make it easier for those who may have retired or thought about retiring to re-enter our workplace also. One example of that I mentioned earlier in the way that we're trying to support some of the staff with the cost of living discussions at the moment are the increased car mileage rates that have been agreed across the system. to support some of that, so our staff are not out of pocket, but by coming in to do some of that very extra important work in the community aspect of our system. In terms of recruitment, I think this is where the business changes, and as we move towards integration, we can be a little bit more creative and come out of the box a little bit more in how we look at recruitment strategies. We need to be very aware of what are the actual skill sets that we need. We know that there are always some wicked problems and some particular bits of the business that are always very difficult to attract to. So how might we do that differently? But I think it's also about thinking, how do we attract new people to Shropshire generally? Whilst they're here within this ICS patch, how do we as a system support them with more generic type working? Can we move away from some of the typical delineations of working in health or working in social care or working in education, and look at more opportunities where we can be flexible about growing the staff that we have in our systems with the skill sets that we actually need. And there are, as an example there are a lot of generic training programs in development at the moment to look at what are those skill sets that would allow people to transfer much easier between health and social care, so that we can create some different types of career paths for people and attract them into business. Many years ago, I know when dinosaurs roamed the earth and I started my nurse training, when I wanted to be a midwife, at that point in time I couldn't train to be a midwife unless I trained and worked as a nurse. And I then couldn't be a health visitor unless I had previously worked as a midwife and a nurse. And I think it's these perhaps types of all policy development that we're working very much also with our professional leads, our clinical leads and partners in the system of how can we change some of that and open it up to attract people in. There are many people, I think, out in our system who would love to come and work in the health and social care sector, but maybe don't quite meet the career paths as we describe them at the moment. So in terms of the strategic challenge ahead for me, I think that's a very high level overview. Between now and March, we need to have the Integrated Care Partnership up and meeting. We need to work on our integrated care strategy that looks at our health needs and wellbeing needs. We need to have the board move that forward into that 5-year programme of work, all between now and March, at the same time as we're building our governance and our experience as a new system of coming together. Given in mind those timelines, one of the questions I had here today on the future working arrangements is how can I work with you in the overview and scrutiny committees, with our ongoing consultation and engagement processes, to make sure we are tapping in, because there isn't a lot of time. I think we have to plan for it, use that time wisely, so we can bring some structured pieces of work perhaps back through this format to share with you, but very open to discussions of how we might do that.
Okay, thank you, Nicola. That's clearly an awful lot of work to do in a very, very short time scale, so
There is.
I don't envy you at all. But we'll open up to the floor for questions. We'll start with Hilary, because you had us out one go.
I'm sorry, I don't want to be negative, but I'm going to be terribly, because I've been sitting on this board now for 5 years. I've come to so many meetings like this. These problems have been with us for a long. I know they've got worse lately, but they've been with us for a long time. We've been discussing these for years, and every time I come, I'm told there's going to be a plan, there's going to be a consultation, and this just seems to be a total repeat of what has been happening over the last 5 years. The ICS isn't new. I mean, it's been in place for a while now, as far as I'm aware. Why? Can you not draw on what has already been done? Why is it all being done again? I suppose that's a very simple and very cynical. I'm afraid I'm sitting here with a sinking heart because I've heard it all before so many times. I'm thinking, why do we bother? Really?
I think that's a fair point. I think we probably all feel like we've heard it all before. From my perspective, I talk here as an individual. Firstly, the integrated care system and the board had its inaugural meeting in July. So the Health and Social Care Act switched in July. So from that aspect, some of the powers to take forward this work are relatively new. One of the reasons that I think drew me back into the system from overseas, I think, is that opportunity now with the new governance to actually change how we are putting our plans and strategies together. So I know that the Hospital Transformation Programme, for example, the Local Care Programme, have been talking about their plans individually for quite some period of time. The position that we've got to over these last few weeks, as I've arrived and I've been talking to them, is that now that's going to move forward into being one piece of work, supported by the capacity review that we're talking about. So rather than each of them having separate governance, it will come together as one thing, as one programme of work. And I think it comes back to what I think one of the points I made at the beginning for me is how do we truly move away from collaboration? Because I think you're right, I think that's what we've had. We've had collaboration, we've tried shared governance and shared decision making and so on, but it hasn't cut it. So for me, it comes down to the label on the tin, which is integration, which for me has to become a very real thing. That means about breaking down the silos, the structures, the separate budgets, and drawing it all together again as one. I don't know that I can be perhaps any more positive than that at the moment for somebody who feels like they've lived through quite a few reiterations of this conversation. You know, I get it. But I guess part of the question is what would make it feel differently for you? If I'm coming back into this committee in the future with progress reports of where that's going, what will make it feel like it's starting to have teeth for you?
I don't understand why it hasn't happened in the past, I suppose. We've had all these, we've had the CCG, we've had the Chief Executive of the NHS Hospitals Trust come here and say, we've got this plan, we've gone out to consultation, this is what we're doing. But none of it, I don't know, has it worked? Are those plans any good? Are your plans going to be different? I understand what you're saying about integration.
We're going to build on this, aren't we?
I can't quite get to what I'm trying to articulate, but I just feel like I've sat here and heard this so many times before.
Yes.
And I'm getting very cynical about the whole thing. I'm sorry.
Go on, Heather.
Can I build on this a bit? This is all wonderful if it happens. I see no mention in any of this about the Fuller report, which actually most of this should be based on, quite frankly. I see no mention here that this is anything other than an ICS for the middle of Birmingham or anywhere else. Nobody here has referred to the fact that we are sparsely populated for much of the county, that actually geographically access is really difficult. This is all so high level, but there's been absolutely no reference at all to the fact that actually we can't do the same as an urban area. I'm really concerned that yet again we've got another meeting where none of the things that we raise at every meeting has come up, which is about access, geography issues, that actually we've seen a health service that thinks that it can tell us where we can go for a meeting, where we can go for any form of consultation. For the southwest of the county, which is highly sparsely populated, we're always told we can go to Shrewsbury or Ludlow or Craven Arms. For any sort of consultation, any way we can dip into anything? No, we can't. No public transport. It all stops at about 5 o'clock in the afternoon, meeting at 7 o'clock means nothing, can't get there. So you can have the middle class and the people who can afford to run a car, and no, we cannot access everything online. So there are huge issues around all of that, and this is really high level, but it doesn't reflect at all the nature of our county, whether it's Telford and Wrekin or us, and all of that. It doesn't reflect urban deprivation or rural deprivation, or any of those things that actually have to underpin the delivery of anything across Shropshire at the present time. So, and my question halfway through was, okay, so where does Scrutiny fit with all of this? I've got it written down here, and now you've asked us. I think it needs to fit at each of these stages, so that actually, when one of these, it's not a pillar, levels comes up, and you've got a piece of work, we need to scrutinise that and say, you're working around Telford, you're working around Shrewsbury, you're not working around Whitchurch or Ellesmere or anywhere else. We have to have that input at all of that. And the consultation bit, which is going to be vital, we really have to have a major input into, because otherwise, yet again, it won't work. I can remember, I don't know whether Derek does, the consultation that was going out on Future Fit was quite frankly unintelligible to the public. We can't have that again, because the public won't wear it again, and we certainly won't. And to come to your recruitment point, the recruitment is just dire. It's boring, it's not interesting, it needs innovation in the workplace for most of these people. It means looking at the whole system, but it also needs innovation in how you advertise, because at the present time it's on the NHS website and it is chronic, really chronic. And we could have an input into that, actually, a significant input into that. I rest my case.
I don't know who was first. Derek, go first.
Eight before you. Us young ones have to look after you. To be honest, I'm only going to echo exactly what's been said here. I was one of the first chairs on health scrutiny in the country. We set up well in advance of most other areas. And we've heard the same stuff, the promises of a better tomorrow. And in actual fact, it's got worse. Time after time after time. And we couldn't be in a worse situation. We've got an ambulance crisis. We've got a hospital under special measures. We've got primary care, worst it's ever been. And every aspect of the NHS is under severe pressure. And now, and we talk about winter pressure, we haven't talked about winter pressure, have we? And that's before we start. We have got still high levels of illness within the county. We've got mental health at an all-time low, struggling like hell they are. And we need to actually, you're asking, what will you expect from us? Or what we expect from you? We expect to be able to sit down and talk about each service. We don't want to hear about it in the press. As so many times we sat down here and they painted this lovely rose garden, and we went home only to find in the press, there's the crisis on. This is what's happened. In the maternity scandal. Why would people want to come and work for you? Why does anybody want to come in? Why have we got people who are, eminent doctors travelling past our hospitals in order to go and work in Stoke, in Birmingham, and everywhere else? Because that's what we're facing. The NHS have got no faith in. And quite frankly, I'm not impressed. With the one thing I've learned is this, that the NHS don't open up. They like to be in control, particularly the hospitals. They love to be able to pull the chains. And when we talk about an integrated service, it is not about talking to our partners, it's about working with our partners. It's about changing what's happening. It's about actually making sure and delegating some of the responsibility, but also not the responsibility, but also the money to go and change that service. Because the ideal of an ICS to all of us in this room, were really, I think it's a brilliant idea, and it should have been done. But we have sat for the last 3 years since we've been talking about it, and we've seen nothing. I mean, you're now coming talking. The first thing we should be talking about is input and output. How you get in, because that's been in crisis for, what, 7 years? We've always had this problem, and now we're coming up with yet another new plan. It can't go on, this new plans. We've been cut back by £200 million by the government for a new hospital.
Yeah.
We don't know what's happening. So where's the cuts going to hit? How have you managed to be able to? You've got all these plans that you've been creating the last 3 years, and virtually it should be torn up now, and then we're back to the drawing board. We can't go on like this. We've got to be able to work together, and that means both councils and the hospitals and the NHS, but getting primary care sorted out and mental health sorted out has to be one of those priorities.
Absolutely.
Okay, Doug. Thank you for coming, Nicola. You have to go without saying that it's in all of our interest, everyone's interest, that we get an effective health and social care service as we possibly can for the population of Shropshire, Telford and Wrekin. So a whole range of issues that are scattered around, if you like. And I do try and keep up with a couple of ICS forums that I take part in, so I try and see what's going on in other parts of the country, because I think that's a very useful thing to do. One of the things, and I think it's a theme that's come forward so far, one of the things the NHS has never really got to grips with is, in order to serve a population, you build up from the bottom. That's how you deal with health needs of the population. You build up from the bottom. You don't do it top down. Okay. I can't tell you how many NHS reorganisations I've been through, but pre-Griffiths and from there. But we still haven't learned that basic lesson. We talk about one of the key, in fact, I think, if I remember rightly, the very first thing that ICS is going to do will be look at health inequalities. The first thing I would do would be to take a large bottle of whatever I wanted, go home and take the last 3 years Public Health Director annual reports and work through those, because it's all in there. For Shropshire and for Telford and Wrekin, it's all there. All the health inequality issues are there. No one needs to look at it again. No one needs to anymore. Start there and then see what the gaps are, what the issues of how to address that. Sorry, anyway, and I guess I'll roam around a few things. In the early stage, NHS England weren't very happy with the size of Shropshire, Telford and Wrekin RCS, were they? We're one of the smallest in the country, not the smallest country population-wise. One suspects that, sorry?
The smallest.
The smallest. One suspects that maybe they've gone off the boil of that, but they were talking about maybe Stafford and maybe, weren't they? So presumably no, they've got other things to think about now, haven't they?
Not at this point. Yeah. I would suspect that, given some of the performance concerns in Shropshire, the idea would be to try to resolve those before thinking about any. Yeah. It doesn't really help anybody, does it, to kind of make the task somewhat bigger. Shropshire, yes, it is in a period of intense, performance reviews. So it does make sense to keep it contained.
We've got some really good things happening in Wolverhampton, for instance, in terms of integration and working together. And I hope that we're looking at those, and we're talking to Wolverhampton. I think we are talking to Wolverhampton. A few other bits and pieces. Sorry, you mentioned System People Committee. What's that?
We have a system people officer.
A system people.
System HR officer.
Oh, HR, is it? HR. I think we understand HR.
Well, professionally, I guess I would say that these days most HR people tend to refer to themselves as people, as opposed to HR. For whatever reason that is. Since we do have a people officer for the system, and that's going to become a shared role across the system going forward for everybody. So that will go to recruitment fairly soon. So that person will have kind of oversight across the whole of the ICS. So in terms of trying to get some consistent grip on what's happening with policy and process and planning and strategy around what we're doing with recruitment, with retention, with developing new training programs, would be easier, I think, having it all come under, one integrated approach rather than individual organisations each having their own HR strategy.
You haven't mentioned yet place and
Yes,
and how we're going to focus
place.
and what the relationship with the place arrangements, the responsibilities, the duties, the abilities to do things. Anything
Yeah, very
to
happy
help
to
with
talk
that and understand about how place is going to work
Yeah.
alongside the board and the
Yeah, very
the
happy
party.
to talk about that. I mean, I think you've already mentioned, the issue of things needing to grow up rather than grow down, and the fact that we've done a lot of these plans before already, and I think that's the point really with the place agenda and with what we understand from our health and well-being bodies is that there is a lot of work and a lot of knowledge that's been done already at local level. And it's that knowledge, it's that local level, not the reproducing of those plans, but the condensing them into a set now of clear policies and priorities that will be the basis for the big piece of strategic work going ahead. So it will be very much bottom up. The place agendas at the moment are being supported, as you probably know, through SHIP and TWIP at relevant sites. All that is still very much ongoing. Obviously, the direction of travel over a period of time, as we're working through those strategic plans, is to shift not just responsibility, but resources and authority down to place level work. So all within an overarching framework, but with a lot of delegation down to place.
So can I pause, Steve? I think Heather's going to pick something up immediately, isn't she?
What is SHIP and TWIP? What is it?
So SHIP and TWIP are the improvement programmes for Shropshire Health Improvement Programme and Telford and Wrekin Improvement Programme, and they are working at a very local level to understand the local needs assessment of the populations at place level.
Are they? So are they going to involve us at all? We were only elected and represent a few people.
You're probably more.
So each place has got their own health and wellbeing boards, and underneath the health and wellbeing boards, there's the Shropshire Health Integrated Place Partnership, which sort of supports the outcomes from the health and wellbeing board. It helps deliver the plans that are in place from the health and wellbeing board, and Telford have the same, which is their Telford Integrated Place Partnership. So it's a group. It's a group of across all of the organisations coming together to help to deliver this health and wellbeing strategies as well as the place plans.
But that's not bottom up. That's middle of an organisation. It is not bottom up. It's not actually doing anything from local communities. It doesn't represent any of us. Do we get to scrutinise any of that? Because it will have a fundamental impact on everything. And if the ICS believes that is bottom up and that is what communities want, it could be vastly wrong, as everything else has, because we have no bottom up working and bottom up work so far that's ever been done.
So I guess there's two things. I mean, I can speak from a Shropshire point of view. Obviously, well, there is the primary care networks, which are represented on, I should have said that on the, and then on the SHIP and TWIP. So the primary care networks are represented. They're a smaller geography in NHS terms. In terms of the health and wellbeing board, obviously we've got our joint strategic needs assessment that we're developing, which is place led, and that's the process we're rolling out across Shropshire. So it'll be the place plan, 18 place plans that we're rolling out again, and that's where a lot of the engagement is going to be happening.
It's going to be happening.
Is happening.
because it hasn't happened, and the Bishop's Castle area has had no idea about any of this, and our populations are significantly living in a health desert, and actually nobody ever asks us what we want, ever. And it looks as though we're going along that path again. And it'll probably all be doing Craven Arms and Ludlow yet again, or Shrewsbury.
Do you want me to tell you a little bit more about the joint strategic needs assessment? Is that?
Yes, it would be quite nice if we did actually have some sort of feed into that. And as for the doctors' groups, they're doctors, it's not patients.
No, absolutely. So in Shropshire, from our point of view, in terms of the joint strategic needs assessment, recognising that a lot of that has been done at county level. In 2019, December, so just before we went into COVID, we agreed that we'd have a place-based approach, and that's based on the 18 place plan area geographies. Within each of those geographies, there's a rolling programme. All the data's been collected for that area, and we're starting to consult, rolling through. So there's ongoing engagement. The area that we've done at the moment, because it got paused because of COVID, we've done Highley. I've just been at Highley this morning, and that was a group of stakeholders with the local members, parish councillors, the local GPs were invited, so that is starting, but it's taken a lot longer than it should have took. And absolutely, the purpose of that is to make sure it's bottom up. It consults local communities on their health and wellbeing needs, and it reflects each area, and we'll bring that together for different geographies depending on what the needs are. So, for example, in the conversations we've been having in Highley today, transport is being picked up as an issue, primary care, so all of those local issues. Some of them might be county-wide, and some of them will be very local issues in those communities. But it's taken. So recognising absolutely we need to consult locally with stakeholders, with our public, and that is through the Health and Wellbeing Board. We've led that process, particularly in Shropshire, but it's taken longer to start than it should have taken because of COVID.
And in my experience of the place plans, we've had one meeting in the last
it's the place plan geography. So it's based on the 18 place plan geographies. It's not the place plan meetings as such. You'll be pleased to know in terms of Bishop's Castle, they've just started. They're going to just start some of the engagement there. So it's been
no. Well, what about my division? We're in Wales, are we? Or we're not involved because I haven't been involved in the Bishop's Castle thing. Furthermore, my division is usually left off because we're not in Bishop's Castle, and we have cross-border stuff. Nobody consults us about who should be there or anything else. And literally half my division gets left out. The same with Clun. Half of Clun division gets left out. This is not about Bishop's Castle town because that's what it always ends up as.
I think if I pick that up outside the meeting with you, because we haven't, because we haven't gone into that detail yet. But as I said, we've started in Highley, and I can pick all of that up. It's been through the Health and Wellbeing Board, and I can share all of that with you. But that absolutely all members will be engaged in that process.
No, it's not being engaged in the process, engaged in how the process is going to happen, because otherwise chunks get left behind, and yet again, the chunks are not represented on any of it. I'm so furious about all of this.
I think take that one up with Rach from outside the meeting.
Yeah.
Kate.
Thank you.
Kate
Halliday.
No, Kate from waiting on.
Kate Halliday, I'm a councillor in Bellevue, Shrewsbury. As you can see, us councillors are very opinionated and grumpy at times, but the reason for that, there is a reason for that, which is that we meet regularly with our constituents, and our inboxes fill up with the issue. So you were asking what, how we can feed into you and vice versa. And I guess this is, although we can be grumpy, we do represent the areas that we're in, and there's been, I won't go into the mistakes that have been made in the past from health. You've already acknowledged that it tends to be quite top down. So I think that what we can do is help with getting that better, get that right in terms of consultation. And I know certainly in terms of recruitment, although Heather didn't mention it, they did some great work, as in the councillors did some great work in driving forward NHS recruitment. And so I think there are a number of things that we can do in terms of actually working with local communities, and I think that hasn't always worked especially well with the NHS. I think as well as a council, local government hasn't really changed for a very long time. The health, how many reorganisations and reiterations have there been?
Absolutely.
PCGs, PCTs, CCGs, ICS. That's just been the last sort of, I don't know, 15 years. Council stage largely the same, and that's not always a strength, but I think there's
stability to it.
There's a stability to it, and within that we do understand local communities and there are amazing resources. And I think when you start to widen that out and start to look at things like prevention, I think the council is excellent at prevention. Potentially every contact counts. We might be seeing someone for something completely different, but we can deliver a health intervention. There's great stuff that we can do in terms of after someone's been in hospital, etc. But I guess I'm kind of getting around in a very long-winded way to my question, which is the ICS is in some financial difficulty, isn't it? As is the council, and this, which I very much, I very much support this direction of travel with the ICS, and I think this is the way to go. But realistically, are we going to be able to achieve much? Are we going to be able to invest in anything to make this work?
Okay, I'll address some of that if you don't mind. I appreciate the frustration in the room. Again, I've been away from the NHS for 20 years, very good reasons. And I left at a time of circling PCG, PCT, when quite frankly I was probably somewhat tired of reapplying for my own job and going through the same process, and I've been away for a long time. And I've spent a long time working in integrated systems doing this. So I would like to hope, for what it's worth, that I haven't taken what is quite a significant pay cut for me to come back to the UK and NHS to kind of, mess this up. I can only kind of give you that as my indication, I guess, as to why I've come back and why I'm here. And I would hope, and I can see why we would be negative about it, but as an inherently probably too positive person, I think we have to be and grasp the opportunity now we have the legislative change. In terms of timelines, one thing I would want to say is our need to engage and to consult and co-design isn't an aim or an idea. It's actually a mandatory responsibility, and we have to demonstrate it. And when you look at the timeline, that's factored to kick in from October. So we've only just had the guidance of setting up an ICP. I still don't have the guidance from Centre as to what they want in the plan and what they want for the 5-year view. So timelines get quite entrenched.
Use it to a state.
But we do have a team of people ready and working on some process kicking in from October, and hence part of the question today, to understand how we make this as an authentic a process as we possibly can. So it's not just about consulting, it is about engaging and co-design. And that is my promise to you for what it's worth, as to what I want this to be. But you can see the timelines. It's why it becomes pressing for how we collectively understand that the best way, the best places. So when we get this team ready to go in October, we know who and where and why and how. And as you can see, that hasn't even happened yet. So we have a bit of time over this month to think about how we get that set up properly. We're pulling together communication and engagement teams from across all of our partner organisations. So it's not one person sitting with me, it's pulling all of them together to say, right, how do we structure this now to get out and about? How do we make sure that all the good work and all the knowledge that has already happened, all those plans that have already been discussed, don't get forgotten? We don't go through all that again, but we do have those discussions and those checkpoints that this is looking like it's right. In terms of the resourcing, I do think that we can make an impression on this, but not by doing the same thing. So one of the things that the new statutory powers allow us to do is to look at funding in quite a different way. Previously, everything's been about sharing, negotiating, jointly commissioning. Now we genuinely have the opportunity to put money in one pot. We haven't had that opportunity before, but to do that, we have to put an architecture down in front of the system to say, well, this is us. This is what integration means to us. This is a plan. This is what we're trying to achieve. This is how. Now we take all that funding and we have to look at shifting activity as well as cost to the most appropriate places. One of the things that the initial capacity review will do that I've spoken about is look at how we're currently funding and addressing health in the system. So if I take an area like cardiology, and we look at how we actually, how people access and receive that care at the moment, and we can cost it out as well as look at the capacity. We can then think about how would we do that differently, how would we do that better, how would we shift how we're providing that, and recost it and shift it. That bit of work has got to come first though. The plan, we're all bought into the same thing, the priorities, money all in one pot, and that we're genuinely looking to do things different and not moving from that, you know, nicely collaborating to no, actually we are all one thing. For me, that's how I'm used to working, I guess, in Australia, and that's the only way it can work.
Okay, Hilary.
I'm going to go back slightly on what I said earlier now. Is there any the Future Fit Hospital Transformation Programme, and I say that with my head in my hands, is so old now.
Yes.
It's got to go back more than 10 years.
Yes.
And things have changed so very, very drastically now. And the funding has changed. Are you going back to look at how that fits in with your plan?
Absolutely. Yes, absolutely. And the local care plan.
So
both of them need to contribute to the needs that we have.
With
not the plan that they want on a page
no,
piece of
because
paper, but
the
needs that we have.
Yeah, that was very top down, and we were told that when the consultation didn't go the way they liked, that didn't make any difference. Okay, well, this is from a Telston-Wrekin point of view, I know, but that is what happened, because I sat here and had an argument with the CCG about that. No, we're not going to change our plans. The consultation can't do that. I mean, is there a possibility of changing what really so old? It does need looking at again.
It'll have to change. Hence the capacity review. And this is always the problem with these big pieces of capital development in health. That we go through a consultation process. We get what seems like the best plan on the page. But the whole process then takes too long, that by the time we come to delivering that process, we have different people around the table, we've got different priorities, and the world's changed. Moved on. So you're absolutely right. And we also have the local care programme coming in with a range of offerings from the community as to where we can expand and change and provide care differently in the community. And it has to be, and it has been from me, the same story to them, that we can't have a build it and they'll come. We're not building more and more community services to suck up unmet needs. We have to have the two come together so that what we're addressing and seeing and understanding collectively as this is our needs across STW, HPP and the local care programme have got to come together as two of the offerings of that. But there's going to have to be a lot that's going to come from elsewhere. So yes, they will have to change some of that. Now, because they're moving quite quickly, because the business case process, a little like things like this, unfortunately drives us to certain timeframes of delivery. Whatever comes out for the next round of their business case will have to be drawn quite quickly. What we have talked about, though, is within the 5-year plan, part of that process is an annual review of how on track we are. So whatever the start point looks like for HTP, we have that annual process over 5 years to tweak those numbers and shift that around going forward, along with the community offering as well. So it's not a lock it in now and then it rolls out over the next 5 years. It's we start, but we're going to have to be nimble and adapt it as we go on.
Is that money going to go into the pot as well?
Yes.
Heather.
So there's a huge pressure on time for the consultation and so on. Isn't there a risk that this is going to end up being top down because you won't have all the information from the bottom that you actually require?
Well, I think we've got a good start with a lot of the work that's come out from population health, from the health and wellbeing boards, to start a conversation at ground level before I almost even become involved in the macro picture, because we are building it up. So rather than, I think, work coming down from me and the ICF's level, it will be coming down from the health and wellbeing boards, which is a much shorter distance than from me, because we really do need to understand the population health.
Unfortunately, in the past, using all that data, it was not delivered for the very rural bits of Shropshire.
Yeah.
Because actually, we always look at the numbers of people. Therefore, if we die more slowly, then that doesn't matter. It doesn't matter if our ambulance response times are much longer. It doesn't matter if we have to travel 20 miles to get to somewhere with no public transport. It doesn't matter, because we don't count, because 200 square miles has only got 10,000 people in it. And that is my worry about what the Health and Wellbeing Board's doing and what they're doing with the data, because the data is always used to fit what's going to work centrally. And I really need some proper assurance that that's not going to happen, because if you live in a rural area, you can't be assumed to be wealthy and to be able to get a private ambulance when you want one, or be able to go and get a private appointment at a hospital, because most of the people living in the southwest are not. We are a very low wage area.
So I had a similar discussion last week with Councillor Morley. Excuse me, I'm learning who you are, Celia?
Oh, Cecilia Motley.
Celia Motley. I'm sorry. Forgive me while I'm still learning everybody. And a very similar discussion at that committee meeting, and some very similar points made, that equity does not mean it's about the most of a situation. And I think it's a fair point that that equity in rurality is part of this conversation. We have deprivation in populations with high numbers, but we know we've got deprivation in areas where we have sparse numbers. And if we're following the 4 aims that we've been given here around equity, that's got to be part of it. And I think as those place boards are developed, and they're fairly new and finding their feet at the moment. And bearing in mind, we've not got to the point where things have really been delegated down to place much at this point in time. But when we do, I mean, that's where some of the conversation has got to happen, isn't it?
But it is, and that's where I need the reassurance that actually the time frame won't mean that it's made in the middle, that actually we do have chance to scrutinise some of that, because it's absolutely vital. And that's why I wanted that reassurance, because at no point has that bottom-up approach been taken ever. So any of your data is just data. It's not actually what people need and require on the ground. And I do hope that if you're going to be looking at that, you ought to look at the huge piece of work that was done in the Bishop's Castle and surrounding area around the use of the hospital. And that was done, I don't know, 6-7 years ago, which had real innovation in it, and it's all been shelved. Nobody wants to know about it. And in fact, most people can't even remember about it.
Is that the bit of work through Oak Group?
It was a local group, the GPs, all sorts of local people put together a plan for the hospital, which of course has now been closed.
Yeah.
Which shouldn't be closed, because you need the beds.
Yeah. Community hospitals will be involved in the review that I.
Yeah, but the community hospitals have their own views. You have to talk to the public, and if you look at that piece of work, it's about the public, and it's the bottom-up stuff.
Dan,
carry on. Thanks. Quite a few boards are now meeting in public. Have you started meeting in public yet? The board meeting in public?
Yes.
Oh, good.
Yes,
And
ICB, yes.
and the minutes are available, publicly available. Oh, good. That's great. I think
There has only been.
you didn't know that, did you?
There has only been.
I don't even knew
one.
that.
Of course, the inaugural board meeting
good.
was in July. The next board meeting is coming up on the 28th of September, for which I think the agenda is coming out very quickly. I know
So we could
because I've
get that
got people
on the
reading.
on the website.
Yes.
You get the details on the website.
Yes.
Great, okay.
Yes. Yes.
You were talking about flexibility being able to move money. There has been the Better Care Fund.
Yes.
To some extent, we use that. It's an extension of the Better Care Fund now. I mean, it wasn't as big as and maybe it wasn't as used imaginatively as it might have been.
No. It's a bit more radical than that, and I think it's going to take us probably time as individual organisations to get everybody moving towards it, and that's why having this shared central model and plan for integration and what we need to do is going to be so important, because what it effectively means, at the moment we can work within pockets of health to be quite flexible of how we move our money around. The strength of the agreements in Health and Social Care Act moving forward will allow us to effectively pool all of our money. To do that, of course, with our finance directors and to meet individual obligations that sit within the system. This is where that shared plan of exactly what we've got to do is going to be so important, because once we know that, then being able to get everybody to a comfortable place where we do see all the money that, in simple terms, seeing all the money that we've got collectively as one pot of money to address the whole of the system is what is in the powers moving forward. But obviously there are logistics to get to that point, aren't there?
Okay.
It's not like from day one we can tell everybody
that.
toss all your money in here and everything will be fine. We have to build a degree of confidence in the system.
Two quick pleas. The NHS has never been very good at planning major projects. The cold hand of NHS England, or what used to be Department of Health, the cold hand of the Treasury means inevitably, whenever you build something like a hospital, it's usually 10 years out of date for what you need then. So the plea is flexibility in building, so that you can adapt to what you find when you actually have the thing in place, as opposed to what you thought it was going to be when you planned it 10 years or so ago. That's one plea. Second thing is, what the NHS also isn't very good at is communicating with the general public when things change. You know, we said this before about what people can expect from their GP. That's changed a lot, particularly over COVID, but not very much communication to the general public about why it's happening, what they should expect, and how they use it. So there's a lot of concern public. I can't get hold of my GP, or I have to talk to a nurse first of all. But if the NHS communicated with the general public about what it was doing, why it was doing it, how it was doing it, that would save it. Sorry? That'd have been a novelty, wouldn't it? Yes, I mean that would actually help a lot, I think.
It would help as long as it's in English, because a lot of the language we've heard today is Joe probably couldn't have a clue what we were talking about. And it links up with what Heather said about your adverts. If the adverts are in double Dutch, nobody is going to apply anyway. I mean, the one thing that stood out to me was systems people officer. Well, I've been a councillor for over 10 years. I haven't got a clue what one of those is. It's.
But now we know.
Plain English, isn't it? Yeah. Derek.
Yeah. I think what Hilda's actually turned around and said is absolutely smack on the button. You're great at you can consult, but you rarely listen, and that's a problem. And I think under the pressures of the new plans and everything else, and the speed we've got to go ahead, I think that will become even more obvious. If you're not going to listen, don't call it. Think you say, this is what we're doing, because that's what we've seen year after year after year. Going out there, and we've seen it go across the whole of Shropshire and Telford, meetings in all over the place, and nothing changed, not one iota. Well, if you ain't going to change it, don't call it consultation, because you're not consulting, you're actually dictating. And that is not the way that you're going to build any confidence in this. And working from the bottom up, when is somebody going to come up with a plan to help our doctors? Because they are our first contact. They are most of the people's contacts, and they can't access them, they can't get into them, they can't make appointments, and half the time they can't even get through by phone. If you are stopping if people can't get into the doctors so they can actually talk about it, where are they going to go? They're going to go to A&E. Yeah. And that's what's causing the problem. And half the time, the doctors in our area are so under pressure, they're automatically going to say, go there. Phone 111, go to the hospital. And everything is being pushed up there. All you're doing is making more pressures. There has to be more help on the very basics, the very entry level of NHS. And that's helping people get things done within their own local area. Nobody wants to travel miles. And I think the hospital is probably one of the worst offenders, because they're making appointments for cancer operations in Telford, and then sending them to Shrewsbury for a COVID test, which is 40 miles, 2 hours, just to go there for a COVID test. Then they cancelled the meeting on Friday. So they're making it so difficult, and people are getting so resentful that they're not going to accept change. They're just really fed up with the way that the hospitals are running themselves.
Well, there's certainly lots to do, but I think, we all have a responsibility. I know, I feel the weight of the responsibility in my role to change what we're doing, as I hope that we all do. I think it comes back to my question, and it's a genuine question with this group, with overview and scrutiny. How do we make this work for you? Because, once we do get into October, we will be starting to think about that process of getting out and about, looking at engagement and consultation, starting to pull documents together to put out. And I think it's going to be a question of put something out to start the conversation, so we're not starting with a blank piece of paper, but we want the input. I want the
consultation
input.
is so difficult with the NHS unless there's something under threat. Something under threat, and people want to come go in their own ranks to meetings. But general consultation about something for the future, what do we do, etc. Very, very hard to get people to really engage with that.
Well, remember what we're talking about now, hopefully, and it is a slightly different conversation, granted, is about the health and well-being needs of communities. It goes beyond the typical health conversation, because we know that there are issues where people are going to be concerned about housing, they're going to be concerned about transport, they're going to be concerned about social care. We need to understand the bigger picture. It is now, as an ICS, about understanding the bigger picture. And clearly, as we've alluded to in this room, for rural areas, they are really, really important considerations. Transport, access, where to go, not just for GPs and not just for health services, but for other activities of life and living. We need to pull all of that together.
I think, honestly, if you want to engage with people this time around, you've got to ask them questions. You've actually got to ask them what they want and what they need, and not have it predetermined on an outcome. Because, for instance, I had someone complain to me today that the integration of one medical practice with another has meant that 2 days a week there is no doctor at the surgery in one village. So people with no transport then have to wait a month for an appointment because there's only a doctor there 3 days a week, and they can't physically get to Ponsbury. So there are lots of basic questions that we should be asking, which is the real bottom-up thing. What's going to make a difference in the middle of Shrewsbury? What's going to make the difference in the middle of Telford? What's going to make the difference in the middle of the countryside, or Whitchurch, or out in Wright and 11 towns? Because it will be different for everywhere, because some people have different sorts of access. And have more buses and all sorts of things. So it's those basic questions we should be asking, and then people might take it seriously. If they're being asked if they want a doctor in Shrewsbury, or they want a diagnostic centre somewhere where they can't access it, they just get angry and they can't be bothered because they know it's going to happen.
Yeah.
And so it's got to be much more open. And we've got to start all of that stuff and ask those basic questions. And you'll get some quite difficult answers, but unless we've actually looked at what people need, you're not going to be able to come up with a solution that will deal with any of them. A simple thought.
Jen?
Yeah. An observation probably more than a question. As a newish member of this committee, the sheer frustration, I'm sure, is not aimed at you, Nicola, but it appears from what everyone is saying and has said, I think ever since I sat on this committee, they've seen so many plans.
Yeah.
They've seen no outcomes.
Yeah.
We talk about prevention, we talk about people keeping fit to help them to stay away from these services. We haven't even got we're not able to access any services. The frustration in Telford is being felt, just for blood tests, and there are simple things that can be done. And that's just an observation, really, because you can't answer that. But the frustration is that there's no follow-up. There was the lack of communication here today. We read the minutes out. There was matters arising from the last minute, and again, no follow-up. And that's this committee. So we can't play a part in that for scrutinising. If there's no follow-up, we have no follow-up from one meeting to the next, and committee have requested follow-up reports, and we've been promised follow-up reports, I think, in nearly every meeting we've attended, and that's never forthcoming. And it's quite obvious that the frustration is not directed at you personally, but I'm sorry, but to tell us this communication and listening to consultation is going to happen, they're not following up with a basic report that has been requested by this committee.
Well, can I offer, should the committee wish to take me up on it? I'm happy to be a regular attender for part of your discussion, if you would like, when you meet, so that we have some consistency of conversation. I suspect part of the challenge today is that another one of my colleagues would have come last time. It's been tossed to me as, okay, you're picking up all the strategy stuff now, you can probably go and talk to this, and then you have another person and another discussion, and I appreciate that's not going to work. I'm very happy to be a consistent person to come along, that if I can get a sense of the questions that are outstanding, and issues that you want to be raised, then I can handle that personally, one-on-one, so that each time you've got the same person coming back.
Yeah, I think that'd be really useful. We had Gareth at the last meeting, didn't we? Which is again very useful, but it's that continuity.
Yes.
So you know what the ongoing story is in the background.
Yes, I appreciate that, and sadly I am new to everything at the moment because it's, I just arrived in the middle of June, so
I think at
most
the
meetings
last,
are
the
my
last
first.
meeting, there were 6 issues that were going to be followed at this meeting.
And they
So
haven't.
we need to tell you that at some stage.
That needs to be brought forward.
I think
I think
We'll make those.
one of the things that we can do off the back of this, and I'll catch up with Amanda and Lorna, is look at action lists or something which just consolidates the matters arising. It'll make it easier for the chairs as well, so you're not searching through the minutes. They are.
So we can tick off them as they're.
Well, they can also go out more quickly, rather than have to wait for the 4 minutes.
I mean, I definitely got the briefing to come and talk about next steps for the strategy timelines, but there are probably some specific questions that obviously have not worked their way through to me.
Yeah.
To get back to the consultation, it would be really good if on the ground we were trying to look at outcomes so that actually we know where this plan is trying to achieve at the end. If the consultation, but if they're going to do this consultation,
Would the update change?
then we need to be looking at what the local public, wherever, what outcomes they want. It's those outcomes that are the vitally important thing, because otherwise we have a plan drawn up that actually doesn't hit any of the outcomes that we need.
I think Nicola, it's fairly obvious that you are a newcomer. Because everybody else had a good excuse not to come here.
Can't think why though.
A little bit of picking up agendas, and then suddenly I find there's a big bit of outstanding work to do. But look, I accept that that people are grumpy. Of course, it's not the most pleasant experience for me, but I get it. But look, let's change it. I can't have any impact on what's happened in the past. I just can't.
Could I just come back with a very small question to Rachel, what I wanted to ask before? You were talking about the ship and the meeting you'd had in Highley, and obviously that was clearly not filtered down to anyone that might be aware in Shropshire Council, perhaps apart from those councillors that were there. I just wondered if there was, just keeping a balance, is there anything I don't know what I'm going to ask. Is there anything for the TWIP?
So both JSNAs will have a place-based element within them. In Telford and Shropshire, both will have profiles, which will include more local data. So that will be the same across both areas. In fact, I know that from conversations with Liz. Because it's obviously the DPH in Telford. In Shropshire, we're piloting, and the Highley is the first area, and then we're going across all the other areas, also adding the consultation in, which is the stakeholder engagement with key members of the community as well as the community themselves. And that's the piece of work that we've just, despite starting it before COVID, that's starting. So in both areas, they'll have much more local data, which is used within all the documents we use anyway. So I think we've referenced the annual report, which have got inequalities and local issues in, but we're making that more systematic. So both areas, both Telford and Shropshire, will have much more local geographies, because exactly the point that's being made, Shropshire or Telford isn't enough. There's a lot more detail locally.
But we can expect then in Telford you will be holding similar events to the one
I think
in
that
Highley.
you need to pick that up with Liz, because Telford might take a slightly different approach. We've committed to taking a particular approach within Shropshire, and that's the approach we've started piloting. It will take some time to get across all 18 areas, and that's the piece of work that's being done. That we've started.
And we'll all be intensely grateful if your next one was in Newcastle on Clan. Wouldn't we?
I think Newcastle would be, it's not in my division, by the way.
Not in your division, no.
No, it's all right, it's fine, it's in the south.
Might be next door, isn't it?
No, many miles, but
It's on the Telford Weekend
it's in the southwest.
Health Scrutiny's work programme, so we will be having an insurance update and things around that.
Thank you, Lorna.
Just to let you know.
I mean, one thing I think is important with that is population health data is incredibly important to look. So obviously, local needs. I think we've got a stronger opportunity now than we have previously to sort of really use these joint needs assessments and what that population data is telling us to really, have a more useful conversation than perhaps we've been able to have before, because it starts to shape some questions and it starts to shape some dialogue.
Will you
doesn't it?
try and use some of the data from across the border in Wales, because many of our population actually use GPs across the border?
Yes, absolutely.
And their needs in Shropshire
Yes,
are great, but if you don't, if you
Absolutely.
miss those out,
yes.
you've got a chunk of the population you haven't thought about.
Yes. I'm just flagging that back up again because although you may not have felt all these things as yet, clearly because I'm just about still alive, there are the principles up there are important because they are what's got to shape our work when it starts in October now. And that issue of, as you say, really listening to the voices on the ground and building those relationships and getting out to have those conversations has got to be not just a slide there, but how we're actually going to change this approach kind of going forward in the future. And if we're able to have more regular conversations here, then I hope we can keep checking in with these principles as to whether you are actually feeling that they're becoming more like real principles than something on a slide. So I put that there as much as anything as a warning to me, as well as hopefully some carrot for you, that this really now collectively should be what we're working towards.
Okay.
We wish you well.
Now, are you sure?
We are sure, because actually, if you go around with the right message, we will love you to pieces. Because nobody has delivered anything that we've asked for so far.
And you've always got to include Ludlow in that conversation.
Do you know how long it takes me to get to Ludlow? 40 minutes.
Just one of the things, I'm just looking at that, and one of the things that certainly with the Future Fit consultation they failed to do was ensure that the consultation could influence the policy. And it didn't, and I was told that it never could because the policy was the policy and it would only influence the mitigation around it. You don't actually say there. I mean, one of the first fundamental principles of any consultation is that it can change and influence policy. It doesn't say that there either. So I fear that consultation will again be what you've decided, and anything that the people say will just be subject to mitigation and not actually policy.
It's also a command and control environment in the
CCG.
in the health service, in the sense of
certainly
command
the
and control.
CCG.
It really is. I mean, and you've got to work hard to adapt some of that to local circumstances.
I think it's difficult for all partners at the table now. In reality, potentially, we all have new expectations on his health. What was the CCG now, of course, is kind of pulled into parts of the integrating care board. We've got our hospital organisations, we've got our community organisations, we've got your new version, if you like, of the CCG in terms of NHS Shropshire. We've got local authority. I think we're all having to look at this and think differently. It is quite a cultural change, isn't it? It is quite a cultural change.
It's not quite a cultural enough change, I don't think. Because cultural change would be actually people can change policy.
Yeah.
That's not what that says.
Yeah, I think
time will tell, I guess.
Yeah, I think one of the biggest things is, and I noticed my mate Gerald Deakins on the online, and me and him were chairs when we were doing that consultation, and the crap that came out of that meeting. It really was the expectation, and it is about managing expectations.
Yeah.
Because we were in Shrewsbury in the football ground, and we had all these people here, and they're talking about 8, 9, 10 ambulance stations where, while replacing the hospitals A&E, they were going to be stationed across all over Shropshire. And it was allowed to go on for weeks and weeks instead of saying stop. This is not realistic. It was allowed to carry on. And that was with all the people in there. And it seemed to be 2 or 3 people just leading them on and building up this wave. And of course, nothing happened. But the reality is, again, it's about managing expectations.
But it did cost 4 to 5 million.
Yeah, no, it cost that. Yeah, but cheap it twice the price if we could have done anything.
Well, there's lots of challenges, guys. That's absolutely true. But you also have to think that Shropshire this is the smallest ICS in the system. I think if as a modestly sized, quite tidy, going back to that original map, quite tidy geographical patch with the 2 local authorities, those health organisations, if we cannot manage to improve the way we come together to plan for and deliver and look at the outcomes for the health and well-being of our system, then certainly the rest of the country is going to be in quite a bit of trouble, isn't it? Because we have a lot going for us. We have a lot going for us.
Don't make it work.
There's not a lot of funding.
No.
But then I think everybody is somewhat challenged with
Yes,
that.
but we have been challenged for many years.
Yeah.
Well, I think Nicola will draw a line under it. You've had a fair grilling, to be fair. It's new in the job. It must be.
Let's have a word with Gareth about these.
But,
He's off my Christmas card.
Nicola, thank you for being so open with us, and the offer of regular contact is certainly going to be taken up.
Yeah.
I think we'll draw a list of action
Yeah.
points up of outstanding questions which we need some answers to.
I think some consistency will
Yeah.
help to
Yeah.
avoid things dropping.
So
I know you'll never please everybody, but if you can please this group, it's a win-win, isn't it?
So have
Especially
you,
Heather.
Personal challenge now.
have you decided how we can scrutinise and how we can keep this on track? Because I think that's most important. Because as a scrutiny committee, we complain that we don't scrutinise and haven't been able to scrutinise. And we've come up with various things that we might do, but I don't think we've actually set some boundaries so that actually Nicola knows what we want and how we're going to do it. So do we need to discuss
I think
that?
that's an ongoing dialogue between ahead of the next meeting, isn't it? So, you're new in post, we accept that today, but next time, we'll have some more structure to it.
Could I just say, the consultation stuff starts in October.
Yeah.
We're in September. I do think we should be looking at the consultation stuff before it goes out as a committee.
Well, look, we'll have 5 to 10 minutes after this meeting.
Okay.
And then what we'll do is we'll talk about what we do, and then we'll actually put it formally in writing, if that's acceptable.
Yeah.
Now, to reflect on the timelines of what that they are indicative. I have put a couple of checkpoints in there, really just to make sure before anything moves on, they are coming here. It doesn't address the ongoing conversation or work. It just makes sure I put a stopgap in here for both pieces of work to come back to Joint Overview and Scrutiny Committee to share where we are. But yes, there is that. How is it going to work in between those points?
Nicola, when the chair normally says, we'll leave it there, normally the pen drops and the officer's out the door.
Keen as well.
I am keen.
Thank you, Nicola.
Thank you very much.
Yes, thank you very much.
Thank you.
Anything else been left on the agenda is co-chairs update. Well, as usual, there's nothing from me.
Nothing from me, but we need to still talk about the
Next meeting, I think.
So,
Um,
So we'll close the meeting.
library
Close
Yeah, we'll close the meeting. Fine.